is a very full screen, and there are just a few instructions that I need to give you. Those of you who have joined who didn't hear me say that everybody's on mute and everybody has been blanked out, so nobody can be seen. We can all see Trish, and I'm afraid there aren't any questions. There's no opportunity for questioning today. But those of you who might want to pose questions to Trish, I'm sure you can catch her on Twitter, or you can email her if she's happy to give out her email at the end, which she'll do. Trish is inordinately busy. We're closing the seminar, as I said, so that no one can come in. Should we be Zoom bombed, which is very unlikely, this has happened in the past though, if you could just all dial out and then dial back in 3 or 4 minutes, we'll have sorted it all out. I'm kind of at a bit of a loss as to what to say, Trish, so I've kept it brief, and you can add in anything you like about yourself, but it gives me absolutely great pleasure to have you here to close our implementation seminar series for this year, for 2020. And goodness, hasn't it been a year, and your seminar is absolutely appropriate for such a year. So thank you for offering to do that. Trish, most of you will know her. She needs no introduction from me at all. Her work on evidence-based medicine and implementation is very well known. But probably one thing that is less well known is that in 2016, she won the BMJ Editor's Prize for persistence and courage in speaking truth to power. All implementers need a hefty dose of both of these qualities. And so today, it's to Trish that we turn to inspire us further. So over to you, Trish, and thank you very much.
Wow, well, thanks very much for that introduction, Andre. I'm just trying to share my screen at the same time as responding to your nice introduction. First of all, I would prefer it if people ask me questions via Twitter rather than via email. And the reason is, at the moment I am getting, I'm actually getting 300 emails a day, and I'm very keen to support you, but literally it's sort of dawn till dusk. Now I need to ask you, because I've had to just fiddle around with my screen and things. What can you see? Can you tell me whether you're seeing what you need to see, Andre?
I can see your slide, which has got 3 pictures with a triangle in the middle.
I don't want that. I want you to see. Oh no, 3 pictures. Oh yeah, that's right.
Yeah.
That is what you can see. So you see one slide. Excellent.
One slide with the title.
Oh, that's what I'd like you to see. Good. So I can't see the chat and I can't see anybody else, but I'm going to go through this now. So this was quite an interesting negotiation as to what I was going to talk about today, because I've been doing a lot on COVID, as many of you will know, and less on implementation. But of course, this is an implementation series, so I had to think a little bit about what I was going to tell you today, and I've deliberately been a little bit, should we say, unconventional in the way that I've put this together. And actually, I think it was John who came up with the title, The Unhinging of Research Implementation. All change, please. And certainly my experiences over the last 9 months have really challenged everything that I've ever known about implementation science, or whatever you like to call it. So yeah, let me tell you a little bit about what's been going on. I'm just acknowledging my funders. Got all sorts of funding at the moment to do research and implementation on COVID-19. So let's start by distinguishing 2 different scenarios. On the left, we have standard science with what I'm calling easy translation. We all know the example of dexamethasone for severely ill patients with COVID-19. We know that randomized controlled trials were relatively easy to do, and that they quickly produced definitive evidence, which was pretty much uncontested. It was very easily packaged and sent around the world and changed practice and policy literally overnight. It's one of the great success stories of evidence-based medicine, evidence into practice. And I'm sure we'll be teaching on that example for many years to come. On the right-hand side of this screen is an example of contested science and tricky translation, shall we call it, masks for preventing the spread of COVID-19. And I've illustrated this with President Trump refusing to take the face covering that he's been offered. In this example, there were no randomized controlled trials, at least not of masks in the prevention of COVID-19. Perhaps they were impossible. The reason why they were probably impossible is that if you're randomizing me to wear a mask or not, you've got to test someone else to see whether I've transmitted it to them, because of course the main function of the mask is what we call source control. My mask protects you. So logistically, they're very, very difficult to do. Whether you say they could and should have been done, masking without a doubt became a political issue, possibly the political issue of current times. I mean, this week's issue of Time magazine has got a picture of someone wearing a mask, and they're saying the whole American election is pivoting around that. Scientists were depicted as taking sides. All right, let's go back to our nice, tidy dexamethasone trial. I'm going to define evidence-based medicine as nice, clean experiments on well-defined population samples, which produce definitive findings that can be handed over to policymakers. And many of you will be familiar with this triangle. If not this particular one, you'll see something similar. It's the hierarchy of evidence. The underlying assumption is that you can distinguish good science from bad science largely on the basis of method. And the design that is seen as top quality is the randomized controlled trial. Now, I'm a cancer survivor. I absolutely adhere to this hierarchy of evidence when we are talking about treatments and therapies. I wouldn't be alive if it wasn't for this hierarchy of evidence. So I'm not opposed to it, but I'm just a bit worried that it may be being over-applied. You can see that down below the red triangle at the top, which is where the EBM people want your evidence to be, there's lots of other study designs, many of which are not on this, but as you go down through the rainbow and get down as far as the blue for things like case-based reasoning, this is considered very weak evidence. Well, let's just take that idea and apply it to masks. I've given you a screenshot here of the Centre for Evidence-Based Medicine at the University of Oxford. By coincidence, this is in my department, but it's not my centre, it's Carl Hennigan's centre. And he worked with a colleague of his, Tom Jefferson, to produce some systematic reviews of randomized controlled trials on the efficacy of masks. And the first thing they did was they took everything that wasn't a randomized controlled trial and, perhaps a bit metaphorically, they put it in the trash can. And they then went through with the risk of bias tool, you know, all that kind of thing. And their conclusion was evidence from 14 of these randomized controlled trials on the use of masks versus no masks was disappointing. It showed no effect in either healthcare workers or in community settings. So as far as I'm concerned, we don't even need to wear masks if we're doctors or nurses in hospitals, and certainly not in the community. Now, let's just think about what was happening here. I want to take you now into an area of knowledge translation that you may be less familiar with, but I would encourage you, if you're interested in this topic, to look up the work of my colleague from the University of Oslo, Eivind Engebretsen. He's written this great paper expanding the knowledge translation metaphor. And I'm going to tell you why I've given him a picture of a parrot. He argues, or his team argue, that translation from one language to another is never done by a bilingual parrot. And if you've ever done translation, you'll know that you have a much more active role than just mirroring a set of texts in a different language. You just can't do it because maybe there isn't the exact word, but you also have to make judgments, you have to make compromises, and you have to attend to your different audiences and contexts.
Trish, it's Andre here. Could I just interrupt you and ask you if you wanted to stay on the same slide?
No, are we not moving on?
Not on my screen, no, and I don't think you are on others. I'm getting texts in to ask you to move on.
Right. So wait a minute, that's problematic. I'll tell you what I'll do. I'll stop sharing and I'll share again.
Lovely. Thank you,
This should have gone all the way through. Let's just go again. Share screen. I know what it might be, actually. I'm going to share my entire desktop first.
Okay.
And then go in. Now you see my first slide.
That's right.
And then you see...
And now we see Trump. And
you didn't see Trump. Okay. Oh, well, I'm really glad you can now see Trump. What a wonderful picture of Donald Trump.
Yes, okay. That's so nice.
And then we now have, you really need to take a look at this rainbow triangle with the systematic reviews and randomized trials on the top, and all the other lesser forms of evidence down the bottom. And then I was telling you about the Center for Evidence-Based Medicine and saying that they just picked the top of that triangle they really didn't look at any of the other evidence. Now we're back on. Now you can see the parrot, yeah? I hope you can see the parrot.
I can see the parrot.
Splendid. Okay, I'm just checking.
We're all fine now.
So the idea is that just as the bilingual parrot is a poor metaphor for translating languages, so the translation of research evidence is not a simple act of summarizing and handing over the facts. Rather, it involves a set of judgments and value-driven choices. And perhaps the best example is the idea that you can just take that red bit at the top of the triangle and say that's all we need to look at. That's actually a contestable, a challengeable assumption of what you should be doing. Now, Engebretson draws on Jacques Derrida, and he says the translational act itself is considered by the scientist, or by some scientists, to be a non-act, and the translator a non-actor. The purpose of translation is assumed to be a container of the original message without adding, transforming, or otherwise betraying the original. And if you look at the discourse of the what I would call the narrow interpreters of evidence-based medicine, this is what they think they do. This is what they believe. They are an objective, neutral conduit for the facts. Well, here's an example of some of the talk, some of the discussion that accompanied that systematic review of masks. So this came from the Center for Evidence-Based Medicine. It's still up on their website. They said thinking you're protected means you may put yourself at higher risk. Measures we can take instead of masking can include washing hands, avoiding touching, social distancing, blah, blah, blah. You may also end up touching your face more often if wearing a mask. Masks can become dirty and contaminated. So no evidence was cited on that at all. And then very soon after that was released, about a week after, Jonathan Van Tan from Public Health England put out a statement saying, we are following the science, the definite article, the science. And he said that while the practice of wearing masks seems wired into some Southeast Asian cultures, it's just a cultural thing for those Asians, there's no evidence that the general wearing of face masks by the public who are well affects the spread of the disease in our society. So the depiction of the Asian countries as just having this weird cultural practice, a bit like the way they eat funny food or something. There was no suggestion that the Asian countries might be using or even assuming that they were using some kind of scientific evidence. This same statement was used very recently, just about a month ago, by Scott Atlas, who had recently been employed as President Trump's new coronavirus advisor. This was a very controversial appointment. And Scott Atlas said, Masks work? No. And then he actually cites Carl Hennigan and the Oxford Centre for EBM, saying that there was no evidence that masks work. That was a very controversial tweet because Twitter took it down. They said, this is fake news, you can't have it. You know, and yet they were citing the Centre for Evidence-Based Medicine. So this has never happened before. This is really quite weird, the way this is all playing out. Well, what about this stuff around risk compensation? Actually, a couple of months after the Hennigan-Jefferson statement about, well, if you wear the mask, you're less likely to wash your hands, you're less likely to socially distance, actually, Teresa Marto and her colleagues published a narrative review in the British Medical Journal that showed that risk compensation doesn't happen. In fact, they cited 4 studies that showed the opposite happens. If you're wearing a mask, you're more likely to socially distance, you're more likely to wash your hands, etc., etc. And then this study of face-touching behaviors, which was, they sort of looked at videos, actually, of thousands of people kind of going past a video on public transport, I think. And they found that people touch their face less if they're wearing a mask than if they're not wearing a mask. So there's an interesting, but nothing has been changed on the CEBM website. Okay, so what were these ignored mask studies that were too far down the hierarchy of evidence? They were in the sort of green and blue areas. Well, there were these sneeze videos where, you know, all right, it was published in the New England Journal of Medicine, but all it was somebody sneezing, and then you light it up and see how far the droplets go. And you can measure it very accurately, but nobody was randomized. It looked a bit messy. So that was ignored. And then there were all these stories of choirs. And if you follow choirs, all sorts of choirs, it wasn't just this one. This was the most famous one, the first one, where 61 people went to choir practice. And I think 52 of them got COVID, 2 of them died. Wasn't randomized. It was all a little bit evangelical. It didn't look like science, didn't feel like science. Again, it was published in a very prestigious peer-reviewed journal, got a fantastically high altmetric score, but it was left off the systematic review. And then, of course, there were these country comparisons. So this is Christian Loeffler's work, where you've got up the vertical axis, you've got mortality, deaths per million population, and then along the horizontal axis, you've got time. And they timed it from the first case, or maybe third case or something. And you can see the blue line is the countries that implemented masks by 15 days, and the orange line, masks by 30 days. And then the ones who didn't implement masks. Now you could say, well, New Zealand, what about New Zealand? They didn't have masks. No, New Zealand is in that red line. It's just an outlier. So this is the average. And you can see orders of magnitude, many orders of magnitude, I think 3 orders of magnitude difference in the masked countries from the non-masked countries. But actually this was all dismissed by saying, well, this wasn't randomized, there's all sorts of confounders. And don't forget those Asian countries, it's just a cultural thing. Therefore, we're not going to look at it any further. Now, my argument is these things demand an explanation. Here's 2 professors of, one's a professor of public health, KK Cheng from Birmingham, and one's Paul Glasziou, professor of evidence-based medicine from Canberra in Australia. Now, Cheng says this is mechanistic evidence, he calls it. Lots of mechanistic evidence, those sneeze videos, you can just see that they block the droplets. And given how few deaths there are in, for example, Hong Kong, you can't say masks are harmful, because if they were, more people would have died. And then the opposite argument, well, wait a minute, all these things that might happen. And again, talking about touching the mask, touching this, although actually the evidence suggested opposite. So lots of arguments amongst scientists. Now, back in March, some colleagues and I published this paper in the British Medical Journal arguing for the precautionary principle. And what we said was, we don't have 100% proof yet, but given what is at stake, and we predicted hundreds of thousands of deaths, we said, given what is at stake, Why don't we err on the side of caution? Why don't we introduce a recommendation for masking in crowded public places? Not mandating, but just recommending. And I think this paper did change practice and policy. It took a couple of months to do so. As you know, we went back and forth, but it didn't go down too well. Here are two websites that were set up to attack both my papers and also me as a scientist. So the first website is actually set up by a professor of public health, who's also a libertarian. And this person describes me as leading a charge. So I'm depicted as very aggressive. I followed up by a decimation of straw men arguments. This was actually a peer-reviewed journal that I published in, and I unpacked some straw men arguments. I'm described as having 900,000 Twitter followers. In fact, that's out by an order of magnitude. I only have 90, so I've got nearly 100,000 now. But the interesting criticism was I was absolutely sure that I was right. And that was apparently not a good idea. But in the second website, same paper, they call me the milk curdler here. And the criticism here is that the paper is larded with may this, and it seems likely that. In other words, I'm being criticized for not being sure enough that I'm right, for being circumspect. So this stuff comes out all the time. But here's more, the Zoom bombings. This is why we had to close the talk, because I gave a talk on masks a few weeks ago, and we got a lot of gate crashers. Here's one who signed in under a white male name and just put this kind of stuff in the chat. I've put the asterisks in so that I didn't offend you, but the asterisks were not in what the person actually posted. And interestingly, this was posted before I'd shown my first slide, just when I had my introductory slides. So they didn't know what I was going to say. So this isn't much fun. I do get emails, I get horrible threats, you know, all that kind of thing. Not much fun. Okay, let's move on to the great Barrington Declaration, which you're probably aware of. 3 professors, one from Oxford, one from Harvard, one from Stanford, bringing the weight of these great academic institutions behind them, and they all got flown to Great Barrington, and they signed a declaration, not wearing masks, by the way, and they said COVID-19 is not as bad as claimed, especially for the healthy under 60s, which are the people they're interested in, because those are the economically active people, I think. The evidence base, they said, for interfering with people's lives is very weak, and the economy should be prioritized over further lockdown. So as you know, that's up there. It's translated into about 20 languages. You can go in and sign it. Lots of people have. So some colleagues and I put together an alternative declaration. We called it the John Snow Memorandum, and we said, no, this disease is very serious. It's sometimes deadly. We said all citizens count. We're not just sort of saying, oh, anyone who's disabled or old can just be written off. We also said that the best way to save the economy is to address public health, and that we all need to make compromises for the good of society. All this was depicted in the British Medical Journal as 2 battling sort of groups of scientists. We were at war with each other, 2 camps of action, shielding versus blanket policies. This is a million miles away from the kind of science communication that I thought I wanted before COVID came along. But it got worse, because there's an investigative journalist, Nafis Ahmed, who started digging into people's conflicts of interest. Fortunately, I came out all right, but Carl Hennigan didn't, because they found links with right-wing lobbying groups, talks about a letter, not the Great Barrington Declaration, which Carl Hennigan didn't sign, by the way, but a prior letter with the same sentiments, which he did sign, was described as being based on fringe pseudoscience and co-drafted by a government advisor who downplayed the COVID-19 death toll for political reasons. And this investigative journalist claimed that he couldn't find a single peer-reviewed study by Professor Hennigan about COVID-19 in the scientific literature. And actually the great Barrington Declaration signatories, those three professors I showed you, they don't have, that one of them has his name on a couple of papers. He's sort of 40th out of 43 authors, but otherwise they don't have a publication in the peer-reviewed literature either, which is quite interesting. Okay, so let's now look at political science. Martin McKee and his colleagues have published this paper. Are populist leaders, like, for example, President Trump, President Bolsonaro of Brazil, are they creating the conditions for the spread of COVID-19? And they do a very sort of systematic analysis using political science techniques. And they say the libertarian right is anti-masks, anti-lockdown, pro-segmentation, in other words, getting the old and vulnerable to stay at home so the rest of the society can get on with its lives, and also pro-herd immunity. Another paper by Jason Harsin entitled Toxic White Masculinity, Post-Truth Politics and the COVID-19 Infodemic, he argues that the proponents of these views tend, though they are not necessarily, they tend to be white and male. They tend to be very aggressively confident and hierarchical and dismissive of so-called female traits, such as emotionality, which in this context means caring about the old and vulnerable, for example. They're dismissive of power sharing. They're dismissive of any admission of uncertainty, of not being 100% sure of your facts. Now, this brings me to post-truth, which is defined as relating to or denoting circumstances in which objective facts are less influential in shaping public opinion than appeals to emotion and personal belief. There was an online conference in June all about COVID-19 and post-truth. And Roy Schulman, who put the conference together, wrote a summary, and this is taken from the summary. The COVID-19 pandemic is a unique phenomenon constituting the most blatant expression of dangers of the post-truth age. The period of the pandemic has been characterized by, first of all, less confidence in institutions, a lack of agreement on facts, and I hope the mask example illustrates that, and a blurring of the line between opinion and fact. The pandemic, he says, intensified the need of citizens to find certainty, but they've tended to find it in comfortable facts, in inverted commas, from institutions and entities they regard as trustworthy. And perhaps the Centre for Evidence-Based Medicine is one of those, and that are consistent with opinions that they already espouse. Now let's talk about the mixing up of those scientific, we might call them factoids, with politics, with the wielding of power by elites. And this is Hannah Arendt, who was writing a long time before the term post-truth came up. But she says, if it is the function of the public realm to throw light on the affairs of men, then darkness has come when this light is extinguished by credibility gaps and invisible government, by speech that does not disclose what is, but sweeps it under the carpet, by exhortations, moral or otherwise, that under the pretext of upholding old truths, degrade all truth to meanwhile, think about the way Trump speaks about COVID. Absolutely extraordinary. Actually, Sarah Cooper, the comedian, does a bit of a send-up of Trump, which is funny, but that the satire has a very, very important purpose, because what she's illustrating is that he's mixing up quotes from science with bizarre statements that cannot possibly be true. Okay, so let me summarize post-truth science and COVID-19. At the beginning, research progressed at unprecedented pace and scale. Too little knowledge quickly became too much. We had lots and lots of studies. Facts, however, were very hard to come by. They were often contested. They became saturated with ideology. Uncertainty became a weapon to be used tactically by interest groups. And we scientists became the story. Our flawed assumptions, our personal political allegiances, our interpersonal rivalries. That's what was being written about, even in the pages of the British Medical Journal. So, okay, how do we deal with this? How come I'm still doing it? I'm still going. I haven't collapsed yet. Well, here's 4 approaches. And this is what I told you I was going to talk about. How do you survive? Well, the first tactic is reflexivity. This is a picture of a place quite near my house in Oxford by the River Thames, and I go there every morning very early. It doesn't always look as nice as that. Sometimes I go for a swim, but I have some headspace. I have an hour at least out of the house and just getting my head in order for the day ahead. Secondly, and not nearly as much fun, painful engagement. I have got to read what people say about me. I've got to read the abuse, not necessarily every word, but I've got to know the broad thrust of what people are saying, because otherwise I can't respond to it. I can't rebut it. Thirdly, and perhaps a bit more academic, is what I've called epistemological labor. And the reason why I've put this academic person here pushing over that hierarchy of evidence is, as I've said, sometimes the red triangle is absolutely where you want to be, and that's the only kind of evidence you want to look at. But other times, for example, with the mask argument, you've actually got to look at a very broad range of evidence. And just because something's a randomized controlled trial might not mean that it should sit at the top of your value hierarchy for very good scientific reasons, which have to be spelt out in the literature. And finally, deconstruction. What do you do when you get something like the Great Barrington Declaration, which is a mix of ideology and factoids and goodness knows what? You have to learn to deconstruct it, to pull it apart and ask questions about the underlying components, which are quite difficult to disentangle. So, for example, we could deconstruct the science of masks. We could ask, hang on, what is counted as facts here, and how have those facts become legitimate? It's perfectly legitimate in one branch of science to look at masks purely as PPE, to be tested a bit like a drug in randomized controlled trials. For example, does this mask protect this surgeon against infection? But it's also legitimate to look at it in a different framing, to look at masks as a political issue linked to controversial choices, for example, about the supply chain and who's going to be contracted to supply the masks, and hidden vested interests. And that's a more political question. When I was asked to write for The Guardian about the Great Barrington Declaration, I pushed back on the idea that I was going to counter the science in the Great Barrington Declaration, because I said, wait a minute, we already know this is bad science. Other people have already demonstrated it's bad science. There is no evidence for this herd immunity strategy. The question we need to be asking is a more political question. Who is funding it? And in this article, we did trace the funders of the Great Barrington Declaration and told the Guardian readers what else they were funding, as well as that piece of, quote, science, unquote. So now I'm going to pretty much finish. I thought I'd just show you some of the papers that I and colleagues have written under the broad bracket epistemological labor. And so these are, all of them in their own way, are not just putting out, here's the findings, but also challenging the methods, challenging the assumptions underpinning what other people have presented as science. So thank you very much for your attention. Now, I've got time for some questions, but apparently you're not allowed to ask any. So I'm going to throw back to the chair to see if we have got time for just a few questions.
Trish, that was wonderful. Thank you very much indeed. I'm going to take I've lost my screen now, but I'm going to, can you hear me?
I can.
Yes, I'm going to take the liberty of saying that, yes, possibly we could do that. But I want to kick off by saying, first of all, what a wonderful, and I thought actually uplifting account, and not just because of your honesty and the courage that Andre alluded to at the beginning, and she didn't know you were going to talk like this, the fantastic courage that you're showing in this situation, but also uplifting because I've always said that what COVID has done is to expose both the strengths and weaknesses of everything in our whole culture and society and psychology and everything. And what this has done is to expose both the strengths and the weaknesses of our scientific culture. And I'm hopeful, optimistic perhaps, that what you've described could be the way that we think about science in the future. It's not a simple, objective, top red bit of the triangle. It's the whole range of evidence. So when people use science, they're human beings living in a culture, in a society where all sorts of evidence have to be taken account of, and the politics underlying it and the way that science has been constructed is fundamental to our understanding of it. And perhaps we will learn that lesson as a result of this. And when we look back, we'll be able to mature in our approach, the rather naive approach that some people have had to science. So I'm really inspired by what you're saying, to say this may be a great way forward, as well as being a horrible experience for you. But my word, thank you so much for sharing that with us and helping us to recognize the links between both the science and the culture and the politics and everything underlying it. Thank you so much, Trish. I am going to suggest that if people would like to unmute themselves and ask a quick question, they may do so. But Trish, you may want to come back at me first.
Yeah, I mean, I agree with you, John. I suppose it's really, really, really important not to throw the baby out with the bathwater. I'm absolutely not opposed to randomized controlled trials. In fact, I'm waiting for the University Ethics Committee to approve a really interesting multi-center randomized controlled trials of masks, on which I will nominally be the principal investigator, but actually one of our PhD students is actually leading it. And the reason why we can do that is because scientifically it's the right thing to do. And it's to address this question of whether the mask lowers your oxygen levels, particularly when you're exercising. So, and the other thing that we're doing it for is that all our medical students are feeling rather lost and lonely and unloved. So guess what? Medical students are very sporty, or a lot of them are. And we've got together our sporty medical students, as well as some from King's College London and some from Nottingham University. And they're going to be doing 4 lots of exercise in 4 different masks. Well, no mask, a cloth mask, a medical mask, and a respirator. And they're going to wear oximeters, and they're going to put their results in a online thing. And very quickly, when we get the ethics approval, we'll be able to publish an RCT showing how much your oxygen level goes down when you're wearing particular masks. So I'm telling you that because I'm not opposed to RCTs. It's the only way you could possibly demonstrate a difference between these masks properly is by using each of these students as their own control, randomly allocating the order, and then your primary endpoint is the oxygen level, all that kind of thing. So RCTs are great, but for public health interventions, for complex stuff, we need to look elsewhere in the mechanistic evidence with masks. I've been working with physicists and fluid dynamics professors, and that's we published this paper 2 meters or 1 in the British Medical Journal, and it's all about fluid dynamics. I mean, I didn't understand it initially, but I knew that we'd bitten off more than we can chew when we asked ourselves the question, should we be 2 meters away from one another, or should we be 1 meter or 1.5? And then we realized we were asking the wrong question, because actually multiple different things like the ventilation, like how loudly you're speaking. And so we designed this little chart. That's the only thing I did. I drew the picture, the risk chart, and it went viral really, really quickly. It's now in the top 20 altmetric scores of all time. which is absolutely amazing. And the picture's gone round, it's been translated into 40 different languages and all that kind of thing. Anyway, the point about that is there isn't a randomized controlled trial in there anywhere, because it's all about fluid dynamics. It's all about multiple interacting variables. So whereas for the exercising and hypoxia question, the RCT is right, for the 2 meters or 1 question, that's not the right kind of evidence. And that requires a lot of epistemological labor to persuade people why you're doing it the way you're doing.
Thank you, Trish. I think you can hear me, you can hear John. I'm not entirely sure that you can hear anybody else. So I'm going to pick randomly somebody. I'm muted. Sarah Brown, I can see you now on the screen. You're just in front of me. I wonder, could you try and unmute yourself and say hello?
Hello.
Great, thank you. Right, test proven. Okay, so Sarah, if you want to ask Trish a question, you've got the floor now, but don't feel you have to. Anybody else now who would like to ask Trish a question, can I ask you to go down to the bottom of your screen, use the reactions button and raise your hand, or as Fiona Poland has just done, raise your hand and unmute yourself. Thank you.
I'm going to pass over to Fiona, if that's okay, because you've caught me a little bit on the hop, Andre, so I shall pass over to Fiona, who already has a question to hand. Thank you.
No problem. Thank you for being my guinea pig, Sarah.
Okay, Trish, thank you so much for an exemplary talk. And I wish there were all sorts of other people who are listening to this as well. That relates to my question, which is that I do a lot of community-based research and PPI related research. And I experience quite a lot of anger from PPI groups and the community on 2 counts relating to disagreements between scientists. One, why are they behaving like that? Yeah, why will they not tell us what they know? Yeah, so that's one of the things, and it's a quite interesting reaction. And then the other one is the despair reaction. They will not make up their minds, right? And so my question is about how do we deal with this without, you know, being condescending, asking people to go on a year's course in evidence-based practice understanding and all of those things. How do we engage, you know, with and including members of the public in these conversations where there is uncertainty?
Yeah, I mean, that's absolutely great question. I would say actually it's on the job description of a PPI group to be angry about stuff. You know, I mean, critical friends, but putting that aside, we scientists are human. We scientists are subject to exactly the same cognitive biases and cultural baggage that everybody else is. So that idea that the scientist isn't human, that's a myth. I mean, it's a myth that served us scientists quite well, but it's not true. And I think one of the nice things about being on social media is people actually learn that you're human. And I've put stuff out on Twitter sometimes saying I cried when I got, you know, a particular bit of abuse, and people say, oh, right, we didn't realize you had tears in there that could come out. You didn't realize that you would actually take it that personally when someone you know accused you of something dreadful. But there's something philosophical here as well. I've just finished reading a book. John might know it. What was it called? It was called The Political Science of Crisis or something. It's by someone called Bowen, B-O-I-N. And he talks about, there's 4 of them. I think they're all men. They define a crisis as being characterized by urgency, uncertainty, and something else, seriousness or some threat. In other words, a crisis is inherently uncertain. And you guys know probably some of this stuff around complex systems, that it is an inherent feature of complex systems that there is uncertainty, that there is paradox. And one of the things that you feel under pressure to do as a scientist is resolve those paradoxes, answer the questions, so that you've then got this set of facts and we can go forward. Actually, if you look at what's happened with COVID, in a few tiny areas, like should we use dexamethasone on the ICU, there is now a fact that says yes, if the patient meets the following criteria. But actually what's happened is, as the science has accumulated, we've had, the uncertainties have increased, actually, they haven't decreased. Now that is something that I think intelligent members of the public can get their heads around if we scientists would stop pretending that the goal is truth. We wrote a paper not long ago all about this thing called the central limit theorem of truth. In other words, out there is this thing called the truth, and the scientist's job is to go and get it. It doesn't work like that. And I actually think that if we appeal to people's experience, they know that. You know, many people are parents or they know parents, and you say, look, when you're raising a child, what is the fact about how to bring up that child? And people say, well, it just depends. And so they know there is no certainty there. There's a kind of pragmatic muddling through. And you can say, well, the same thing with science. On the other hand, there are a few things that you can nail down. For example, how long, I don't know, how long cigarette smoke hangs around in a closed classroom with all the windows closed, that kind of thing. You can measure that. That kind of thing. So I think we need a better dialogue with our PPI groups. But one of the problems with the Hennigan, Gupta, Great Barrington group is that they are absolutely convinced that there is a set of facts, and that it's the scientist's job to parcel up those facts and give them to the rest of us. And that myth about the nature of science is probably as dangerous as any specific factoid that they're putting out.
Thank you, Trish. Fiona, I hope that helps answer your question. Anybody else?
Yeah, that was great. Thanks, Trish.
Anybody else have a question for Trish? I think you'll have to make a noise to gain my attention if you do have. I can't see anybody coming forward with a question or a comment.
Are they scared?
Peter Jones has got a question for you. Is that right? Yes.
That's right, yes. Hello, Trish. Thank you very much for such a great talk. I wonder whether you could just say a little bit about long COVID. And this is something else that you've been writing and leading about over the past few months. And it seems that this is something that has been led particularly by patients in the midst of tremendous uncertainty, by clinicians as much as scientists. And it's an example of something that's been shaped by patients through their own experiences, and science and clinical management is sort of coming up behind. So your general reflections would be interesting. And where would you put it on the rainbow triangle?
Oh yeah, no, I hadn't thought about where to put it on the rainbow triangle. Just before I talked to you, just before I started this talk, I was sitting on the oversight group of the National Institute for Health and Clinical Excellence on long COVID. So we're writing a long COVID guideline. And before I joined that group, I signed a declaration of something or other that I'm not allowed to talk very much about long COVID until the guideline is out. So I'm a little bit constrained because I have promised not to say too much. I certainly can't tell you how nice of framing it, but putting that aside, we did do research which has been published as a preprint where we interviewed 114 people with long COVID. And I've listened to every one of those interviews. I've done quite a few of those interviews myself. So I've heard a fair few stories about this. And one of the things that comes across is this enormous mismatch between what the patients were going through and what their doctors were telling them was happening to them. I think this is going to become a very important example of the way science was built, as you say, Peter, by a patient community who, exasperated by the fact their doctors were telling them, no, they must be better. And if they're not better, they must be anxious, or they must have something wrong with them mentally. And actually, they weren't better. So they did research on themselves, and they have now published at least 2 papers in peer-reviewed journals with samples of many thousands, actually setting out what the symptoms are. Now, of course, you could talk about skewed denominators and all that kind of thing. If you join the long COVID support group, you've probably got a particularly bad case of it. That's certainly the case. But one of the things they were particularly cross about was this idea that this really isn't very common. In fact, I got into terrible trouble by quoting a 1% figure in the Daily Telegraph, and they all came back to me and they said, well, you got that figure wrong. And I think I probably did, because if there's something like 60,000 of them in those groups, it can't just be 1%, it must be more. So what's going on there? Anyway, what else to say about long COVID? I've got a whole lecture on it, actually. I gave it last week to a conference in Kazakhstan. It's complex. It is probably an inflammatory condition. It is not restricted to people who were admitted to hospital. In fact, most people with long COVID were not admitted to hospital. But the interesting bit from my perspective as a doctor who's also a social scientist is how the medical profession and indeed scientists completely missed it for a very long time, and are even now playing catch up by reading what the patients themselves have discovered about it. So I suppose the other thing that is, I think, quite interesting is the whole notion of COVID's paradox. I've called it COVID's paradox, which is that the very system of care that we set up to deal with acute COVID is paradoxically the very worst system for dealing with long COVID. So the idea that you can't get an appointment to see your doctor, nobody gets examined, people who just want to kind of go along and tell their story are deprioritized. Everything is all around infection control, et cetera, et cetera. And so well, at the beginning, we made this massive change, probably the most radical change in the history of the NHS as to how we deliver primary care. And now, because that is continuing, primary care is not fit for purpose for assessing, investigating, supporting, managing people with long COVID. And I find that quite fascinating. And I have a lot of sympathy with people who've got that condition. But I can't tell you anything about the guideline.
Thanks.
Okay, Peter, helpful?
Yeah, very helpful. Very interesting.
And any more questions? I think we've probably got time for 1 or 2 more. And I think Trish said, are you scared? Before Peter asked his question. I don't think anyone on screen is scared. Probably just trying to work out a suitable question in the remaining time. So anyone who has a question, please speak up.
I think I'd like to ask Trish when she gets any sleep, but we'll leave that for later. Anybody else got a more important question? You seem to be getting through so much at the moment.
I'm always in bed by 10. My sleep's very important. In bed by 10, up at 6. Very strict.
Another question?
Serious question.
I have a question. This is Barbara from the Netherlands.
Thank you, Barbara.
I don't have my camera on, but
that's fine, no problem.
Followed Trish along through all the years, and for me, you were one of the first people who looked, scientifically at implementation. And I was wondering, I don't know, you've talked about knowledge translation and how things have gone in interpreting research knowledge, but I wondered if your views on implementation, the right way to implement intervention have changed by this COVID epidemic. You know, you're thinking with the baggage of implementation science and how that has influenced possibly implementation theory or practice and things that we can learn from this COVID, you know, in our work in implementation of research results.
Yeah, that is a very insightful question. So on the one hand, I think many of the principles of implementation science that we already knew were borne out by what happened at the beginning of the pandemic. But on the other hand, there were some new things. So at the beginning of the pandemic, one of the things, because I'm quite old now, I've got really good relationships with national policymakers, for example. And the reason for that is that we all know that if you're going to influence policy, you have to have an ongoing interpersonal relationship with policymakers, because the way policy works is they will, I mean, I got a phone call from Canada actually just a couple of weeks ago saying, please could I have a meeting with the chief scientist of Canada at 9 o'clock tomorrow morning, Canada time, because the chief scientist of Canada needed to change policy and they thought that I would be the person to ask. So it's like, that's the time scale of policy making. Tomorrow, we need the answer tomorrow. We're asking you the question today and we need your findings tomorrow. But also you have to have a relationship with that person in order for them to know that they can ask you. So the only way it works, the only way you can actually influence policy is already be on their social network. And so we all know that. That's why we all go to those, or we used to go to those breakfasts at the King's Fund. And, you know, you think, oh, it's a bit of a waste of my morning, but I'm going to go because I've got to press the flesh, all that kind of thing. So one of the things that happened in March was that as the pandemic kind of loomed and we knew it was happening in Lombardy, it was coming to the UK, I was getting phone calls from people in NHS England saying, can you help us with this? Can you help us with that? And I was saying, yes, I can, or no, I can't, but I know someone who can. And there was a lot of that, rapid reviews and co-producing emergency guidance. For example, the total triage, we did that overnight. It really was absolutely amazing. You look at it now and you think, oh my goodness, how did that happen? Okay, so that illustrated some of the existing principles of implementation science and the stuff about getting good data on how you're doing and feeding it into your continuous improvement cycle. So you had to have good data systems, plan, do, check, act, all that kind of thing. You had to use your opinion leaders, you had to use your champions, those kind of social influence strategies, they all worked. The thing that was new to me was just how politicized this was going to be. And although my undergraduate degree was in social and political sciences, now I didn't study that for 3 years, I only studied it for 1 year. And I do remember going to lectures on political philosophy. And it's the first time in my life when I've actually had to go back to some of those principles of political science about how power gets wielded, how vested interests get tangled up with science. I think, to be honest, what's written about implementation science now looks incredibly naive. It really does. So I'm not saying let's throw it all away, but the reason why I was talking about, for example, that Martin McKee paper about the libertarian right is actually, that's what I live and breathe at the moment. You know, that I'm sharing a department with Carl Hennigan and his people. It's not much fun, to be honest. But in order to make sense of it, I'm actually reading more political science, not implementation science. So
great place to stop, I think, Trish. Thank you, Barbara. I hope that was useful. I'm sure it was. So this is the end of our hour, which has been filled very, very well and in a most enthralling and captivating way. So I usually end up by saying some of the things that I've learned. Well, Trish, you've helped me resurface the importance of emotional labour in relation to researchers and implementers from what you've been saying. The absolute criticality of political nous, which of course we were going to ask you to talk about influence, and that holds that there. And this very new term that I hadn't thought of and I absolutely love, epistemological labour. So thank you so much for bringing that to our attention. We're going to close this seminar now. It is the last of the 2020 series. Hopefully, if you watch this space, there'll be some more of those. And Trish will give you 10 minutes before we ask you to reconvene to talk about implementation.